Einstein's Eyes, where we explore the fascinating world of ophthalmology and eye health. So I'm Carl Rosen, oculoplastics, neuro-ophthalmology, really focusing on oculoplastics nowadays in Anchorage, Alaska at Ophthalmic Associates. Today, we're going to dive into a topic that affects millions of people worldwide. Herpes zoster, commonly known as shingles. And I have my partner here, my friend Jon Ditkoff, who we were co-residents at Albert Einstein. Before I let Jon break this down, because Jon's a cornea expert, we're going to explore the symptoms, the risk factors, the treatment options for shingles. And we're going to, as it relates, specifically focusing on the impact of eye health. Shingles is a multifaceted condition, and understanding it can help you recognize it early and seek appropriate treatment, which is critical and important for your eye health. So let's break it down. Jon?
Yeah, so I'm Jon Ditkoff. My practice is in northern New Jersey. I've been there for 30 years. I trained with Carl more than 30 years ago at Albert Einstein, hence Einstein's Eyes. So we've created this channel to give you information about eye health and eye conditions. So shingles. Shingles of the eye is extremely common. It's usually associated with shingles of the face. I think Carl has a picture of it. So it's usually in a certain, what we call dermatome. Do you want
Yeah.
to show that picture?
Yes, let's show that. Can you see this?
I can see that. So Carl's showing a great picture here. So what is shingles? So shingles is a virus. It's in the herpes family. A lot of people, when they come in and I tell them they have herpes virus, whether it's shingles or herpes simplex, it's still herpes virus. In fact, there's other herpes viruses. But we're not going to go into that today. But shingles, the type of virus that occurs, more common in older people. That's not necessarily, they could be over 40, over 45, but I've seen it in younger people as well. But it's much more common in people over 45 or 50. And what's really unique and interesting about it is it's a virus that's there from childhood when a person either was exposed to chickenpox or received a vaccine for chickenpox. And it lives in the nerve, in the ganglion, in that area. It can live there for years, and then something brings it out. There's a lot of theories, but what I've seen in patients is some stressful event, not getting enough sleep, having another type of illness where they're debilitated, or it just happens. And what happens is this virus suddenly that's been living dormant in the nerve comes out. So the first symptom is usually shooting pain, what we call a neuralgia. So it's actually inflammation in the nerve. And so we're talking about the eye today, but it can occur anywhere in the body. When it's in the eye, people will start to have these shooting pains into their scalp, into their forehead, maybe their nose, or even in their eye. And then usually a day or two later, the rash kicks in that Carl is showing here. So if you're having this vague shooting-like pain and neuralgia, it could be a neuralgia, it could be nerve pain, but then if it's followed by a rash, then it's a very easy diagnosis. So I've had many patients over the years kind of look at me and say, oh, my doctor missed this diagnosis. I was having this pain and then I had the rash and they thought I had something else. And I explained to them, listen, we don't know. We don't all have crystal balls. We can't know you're going to get a rash in 48 hours. In fact, an interesting tidbit, years ago, the most common reason surgeons went into the operating room for exploratory surgery of the abdomen to rule out appendicitis, meaning they thought someone had appendicitis, was shingles in the abdomen. Because what would happen is these people would come into the emergency room with these terrible pains shooting from their belly into their right lower quadrant. They had maybe an increased white blood cell count, which means sign of infection. They felt a little bit of malaise. So the doctors were concerned they had appendicitis. And they'd go in and they wouldn't see any problem. And then 2 days later, they'd have this big rash, like Carl is showing. Instead of being in their face, it would be in their abdomen. So getting back to the eye. So what happens is when these people first present with a rash like this, they're referred often to us as ophthalmologists. And the reason they're referring them to us is, especially in this picture, you can see the rash ended up in their nasal area, in their nose. That's the dermatome. That's the distribution that often occurs that can affect the eye. But really, any rash near the eye should be evaluated by an eye doctor. And
Right.
what our
John.
job is to do, yep,
Yeah, John, let me jump in. So I just want to say that the key element here is it affects just one half of the face.
correct.
So it looks like somebody took a ruler and drew a line down the middle of the face and split it into the right and left halves. If you
Yes.
see that with blisters and redness and swelling, then that is likely shingles
Yeah. And
or
most doctors, even medical students, it's a relatively easy diagnosis once the rash is there. Like Carl said, it's a blister, it's painful, and it stops right at the midline, just stops there. And that's why it's very interesting that it doesn't extend. So it makes it a very easy diagnosis. I mean, we can make this diagnosis from if I see someone in the emergent in the waiting room, I can see him from 30 feet away. I know what the diagnosis is. But the question is it involving their eye? So there's plenty of patients that have herpes zoster, dermatitis, which is of the skin, where it doesn't involve the eye. And when it involves the eye, it's actually pretty easy as well. I find most people have some type of red eye. So I'll tell my patients, listen, if they come in looking like this lady, where they have a white eye but a bad rash, I'll look with the microscope and I'll make sure it's not in their eye, but it's usually pretty obvious. If they don't have a red eye, the odds that it's in their eye is pretty low.
yeah, John. So
If they
here,
have a red eye, they can either have conjunctivitis, which is just a red conjunctiva, or Carl has a very good picture, right, of the cornea.
right. So this, we're just showing an example of what the virus can do to the surface of the cornea. And since John's a cornea expert, this is something that would get referred to him, not necessarily me, but to John.
Yeah, so we'll see a conjunctivitis, which is a red eye, and we'll look at the cornea and we'll see some type of inflammation. These happen to be dendrites, which we don't always see with zoster. We see it more with herpes simplex, but we can see it. But the bottom line is there's inflammation of the cornea, and there's also inflammation of the anterior chamber. So the actual virus causes inflammation of many different layers of the eye. And that's why it can be so serious. That's why it can be vision threatening. What's interesting about this virus is the doctors that refer these patients to me, so they'll see a person with shingles, they look in the eye and it's red. And the doctors are very worried. Oh my God, I better get them in your office right away. The reality is it's not that emergent. It really isn't. Shingles doesn't cause blindness or corneal scarring or things like that quickly. But on the other hand, it's still better to be safe, of course. So when we see this patient, what's interesting is we typically want to get them on treatment, but they're usually already on oral antivirals. So they could be on Famvir, Valtrex, Zovirax, acyclovir. These are all medications you take by mouth, like antibiotics, but these are antivirals, so they kill the virus. The more important, so that usually will kill the virus also in the eye. For shingles, I often don't even have to give eye drops for antivirals. What I do is I wait to see that the antiviral that's being given systemically knocks out the virus in the eye. But what's really difficult about shingles in the eye, similar to COVID and many other viruses, is it's the inflammatory response. So it's my job as an eye doctor to make sure that they're on the antivirals, that the eye starts to quiet down in terms of the infection, but then the body's immune system kicks in. And that's oftentimes what causes problem with people that have shingles in their eye, meaning they can get scarring in their cornea from the inflammation. So my job and my role is usually to watch very closely. And if I start to see that the person's at risk for scarring, then I add steroids. And the steroids are meant to prevent scar tissue from developing and visual loss. And the steroids are also important to treat the inflammation inside the eye, which can sometimes cause secondary glaucoma and other problems. So we give steroids and we monitor the people very closely. Hopefully the steroids clear up the inflammation very quickly. But then that's where the tricky part is. That's where the art of medicine really comes in. So I have patients that have had shingles where I give them a couple of weeks of steroids, followed them very closely. It all went away and they were done with it. And then there's other people that every time I back off on the steroids, the inflammation kicks in their eye. So I have patients that had shingles 3-4 years ago that are still on low dose steroids, suppressing their immune response to a virus that's long gone. So what I often tell these patients is what Carl has heard before. What's the difference between a herpes virus and love? Do you know the difference, Carl?
Tell me.
Herpes is forever.
It's true. It's
So
true.
that means that if you've had shingles in your eye, that inflammatory response stays for some people forever. They keep fighting the infection. So we have to modulate that with immunosuppressives, steroids, and things like that. But for most people, it is a short lived issue. What's also interesting about the virus is many people will come in with a completely white eye, like that picture, but they're having these shooting pains in their eye, and they come to the eye doctor and they ask me, "Hey, I'm having it's in my eye, it's in my eye," and I have to explain to them it's really not in their cornea or their eyeball. What it is it's a referred pain type issue. It's a neuralgia, and I often refer them back to either their primary care doctor or a neurologist for medications that are good for neuralgia. Things like uh, what's
Gabapentin,
gabapentin.
right?
Gabapentin is the most common one. Neuron,
Lyrica.
Lyrica. So those are medications that the neurologist. I don't prescribe them. I don't know if you do it, Carl. But for
No.
me, I'm comfortable having their primary care doctor or a neurologist prescribe those. But I have to explain to the person, listen, if you have eye pain, I'm happy to see you to make sure it's not in your eyeball. But there's a very good chance it's a neuralgia that feels like it's in your eye, and then you need those type of medications.
Right, right. So gabapentin and Lyrica and Neurontin. So you have to be careful with those drugs. Those drugs are great for like you said, trigeminal neuralgia because the virus lives in the trigeminal nerve, which
Yep.
then travels through one of the three branches, the ophthalmic branch,
Yep.
and then you can see a blister on the tip of the nose. And that's a particular sign. It's called Hutchinson sign. But gabapentin can cause problems with up close vision. It can affect your focus ability, and sometimes it even causes the eyes to jiggle or to cause nystagmoid movements
Okay.
or nystagmus. But John, you did a great job. I just wanted to highlight a couple things.
Sure.
So one of the risk factors that our audience should know about is folks are usually over the age of 50. A weakened immune system due to conditions like HIV, AIDS, cancer treatments, or chronic diseases can also elevate the risk, as can stress. So if you're under a lot of stress or you had some kind of trauma like a car accident, you also have to add that to the equation. Should you have shooting pains, if you have swollen lymph nodes, it hurts to swallow, or you got a pain at the angle of your jaw, and then you get this blister or this rash just on one side, that's a real tip off that you may have herpes zoster, and you want to get treatment with antivirals within the first 72 hours, and that really helps. And that's how you can avoid also chronic pain, which can happen. And the
Yeah.
chronic
So one
pain,
thing I would add about that, I don't know how you are in your practice, but you brought up a very important point, which is to be treated early. It's really about treating the neuralgia with steroids.
yeah,
So there have been studies, and a lot of the really sharp medical doctors and neurologists in the area, if they diagnose shingles early on, they'll put the person on oral steroids. If they come to my office, I will send them to one of those doctors and say, please consider oral steroids. Not for the eye at that point. It's more about there have been definitely studies, and my clinical experience has been if you give these people steroids earlier on, they're less likely to have chronic neuralgia. Sorry to
right,
cut you
right,
off.
right.
Keep
And
going with
that,
your
yeah, and that postherpetic neuralgia is really, really the biggest issue
difficult,
for patients because
terrible. Yeah.
it can be really be a big problem. And that's called postherpetic neuralgia, and that's why you want to treat early. And some of the medications we use for that are nerve blocks or antidepressants or anticonvulsants, as we just mentioned. Um, John, was there anything else on
Yeah. I
herpes
mean, the only
zoster?
thing I would add for this is a plug to get your vaccine. I think it's offered to anyone over the age of 55, if I'm not mistaken, but we would urge you to speak to your primary care doctor about it because it's there. It's a two-shot vaccine, and it does decrease the likelihood of getting shingles, or it decreases the severity. So I'm starting to see more and more cases of what's called an atypical variant. a little bit more difficult to diagnose because they don't get that severe rash. They don't get as much pain. It's like a mild version of shingles, but it's still there, but it's a lot milder or you don't get it. So,
Right.
Carl, have you had your vaccine?
So, so I have not, but I
Neither
will
have
tell
I.
you that,
I
right.
should.
But I will tell you that the shingles vaccine is a powerful tool in preventing the
Yeah.
painful condition. And the CDC, John, it's interesting. The CDC recommends Shingrix vaccine
Shingrix.
for adults 50 and over.
What's 50 over?
And it has been shown to be more than 90% effective in
Yeah.
preventing shingles and its complications. Yeah, I absolutely should. I mean, it's like a baker who doesn't bake bread for their family, you know?
For me, I really considered it. I was about to get it, and then COVID hit.
Yeah,
And
yeah,
and then I was so busy getting COVID vaccines. So for me, I waited, but I have no excuse right now. I just heard it could be unpleasant.
yeah.
And
So
there are people that have a reaction to it. So I'm not anxious, but it's definitely a lot better than getting shingles.
yeah, yeah. But shingles, the vaccine can help prevent future occurrences, even if you've had it.
Yeah.
And but it's important to discuss, with your doc. John, thank you. We are going to wrap this up. Thank you for showing up, everyone, and we will see you on the next one.